So today we are going to see the topic that is the prostate. Actually, the prostate, if you see, we call it as a fibromusculoglandular tissue. Okay. Why it is so? Because it has got structurally, if you see, it has some fibrous tissue, some muscular tissue, and also the glandular tissues. Okay. What it does, as it is a gland, it is going to secrete some secretions which are contributing the semen in male, and the secretion which is acidic because of the acid phosphatase which it contains. Also it contains some fibrinolysin, prostaglandins, and the zinc which protects the sperm. This gland, as you can see in a picture, it is a conical shape. Now where it is situated? It is situated just as you can see in the picture below the urinary bladder, where the apex which is directed downwards and it is surrounding the proximal urethra, or also we call it as a prostatic urethra, just above the urogenital diaphragm, behind the pubic symphysis, and in front of the ampulla of the rectum. It is embraced by a muscle that is the levator ani. If we look at this gland, it is chestnut appearance. This structure in our body, which has a transverse diameter more than the vertical, that is 4 centimeter. Vertically, it is 3 centimeter, and antero-posteriorly, it is about 2 centimeter. The weight of this gland is 8 gram. Now, some of the structures like this prostate, another structure we know that is the pons, which also has a horizontal diameter more than the vertical. The gland has got two capsules, as you can see in the picture, the outer false capsule and inner true capsule. The inner capsule is a condensation of the fibrous tissues of the gland, and the outer capsule which we see, that is because of the condensation of the pelvic fascia. Between these two capsules, we have the important, that is the prostatic venous plexus. The site is important for the surgical purpose. The condensation of the pelvic fascia also forms few ligaments related with the prostate, that is the puboprostatic ligament, medial and lateral. We have seen in the bladder lecture. The apex of this gland is directed downwards, which is related with the superior fascia of urogenital diaphragm, and the base is directed above, surrounding the neck of the bladder. The gland is pierced by the urethra, not exactly in the center, but slightly in front. So, dividing the gland into anterior 1/3 and posterior 2/3 part. The posterior surface, as you can see in the upper picture, which is in relation with the ampulla of the rectum, and this which is covered by the rectovesical fascia, also called as Denon-Wheeler's fascia. The clinically, when we do the per-rectal examination, we can palpate the prostate gland, and which is important to diagnose the enlargement of the prostate gland. On the posterior surface, we can see a groove which is T-shaped, means horizontal groove is there, and also the vertical groove which is there. The transverse groove which is present will divide the surface into upper small and lower large area, and the vertical groove will divide it into two half. Okay. Now, above the horizontal groove is the median lobe of the gland, and below it, the median groove will divide it into two lateral lobes. Now coming to the surfaces of the gland, the anterior surface, as you can see in a picture, which is convex in shape and anteriorly related with the pubic symphysis. In between two, we get a pad of fat called as retropubic pad of the fat, and also there is a prostatic venous plexus, through which the deep dorsal vein of the penis traverses, and the inferolateral surface of the gland, which is related with the levator ani muscle. Now coming to the lobes of the prostate. The lobes of the prostate we divide it into two, one an anatomical division and the surgical division. Remember, the anatomical division, there are three lobes. Okay, one in front, which is the median lobe, and two laterally are the lateral lobes. Okay. Now coming to the surgical division, which are there are the 5 lobes in which the median lobe and 2 lateral lobes are same, but again we divide the part of the lateral lobes anteriorly, which is present, that is the anterior lobe, and posteriorly, which is present to the urethra, that will be the posterior lobe. You remember that the anterior lobe, which is there, is a fibrous structure lobe. One by one, seeing the lobes, median lobe, which is very important for us clinically, which is a wedge-shaped blue color, which you can see here, the apex directed downwards and the base is upward. And this is behind the prostatic urethra and in front of the ejaculatory duct. So predominantly this lobe is fibromuscular, impregnated with the mucus gland. So if you see the structure of it, there is a fibrous tissue, muscular tissue, and also the mucus gland. Now, the importance of this lobe is the median lobe enlarges as a person goes towards the old age, and then it forms a ball wall obstruction. So it obstructs the flow of the urine, and because of that the person will have a retention of the urine, or the evacuation of the urine will be incomplete. Coming to the next, the 2 lateral lobes, yellow color, what you are seeing, which are the larger one on either side of the urethra and on either side of the medial sulcus. Okay, now the continuity, if you see these lobes posteriorly, which you see the part of it which is posterior to the urethra behind the medial lobe, that is the posterior lobe, and in front of the urethra, that is the anterior lobe. Now this anterior lobe importance is it is more of fibromuscular structure and may persist only up to the 6 years of the age. Coming to the structure traversing, as we have seen the structures which traverse through the prostate gland, similarly the structures within or traversing the prostate gland, again 3 structures are there. One is the prostatic urethra, as you can see, which is not exactly at the center but slightly in front, and this is about 3 centimeter in length, and the maximum, it is fusiform in shape. So the maximum diameter which is there is about 8 millimeter. And if we take a cross section of the urethra, it is crescentic shape. So the anteriorly it is convex and posteriorly concave. The second structure which we see in the prostate, that is the ejaculatory duct. Now this ejaculatory duct, the 2 ducts which traverse the gland, which are posterolateral to the median lobe, traverse and then they open into the, on each side of the prostatic utricle at the folliculus. So in front of that, the tissue which are there, that is the median lobe. The third structure we see here, that is the prostatic utricle, which is mucus in structure and mucus Pulde sac. Means what? The mucous membrane of the urethra will form a Pulde sac, okay, which is about, in length it is 6 millimeter and extends upwards and backward. We can see in the next picture where we can see in the lower part the prostatic utricle, and also the major diagram, a larger diagram which you are seeing. In that you can see the all the 3 structures, that is the prostatic urethra, ejaculatory duct, and also the prostatic utricle, which are the 3 structures in the prostate. Okay, next, what is the structure of the prostate? So as you can see in the diagram, the gland has 1/4 fibrous tissue, 1/4 muscular tissue, and half of the tissue are glandular. Now the fibrous tissue gets thickened at the periphery to form the root capsule. And outside this root capsule, as I told you, there is a venous plexus. Muscular tissue within the gland, they are the smooth muscle, also continues above to form the detrusor muscle. And in the gland, the muscle fibers, they form 2 layers, one beneath the 2 capsule, that is the outer layer, and one around the urethra, that is the inner layer. Okay. So the importance of these muscle fibers which are there is the contraction of these fibers will help to squeeze the contents of the glandular tissue and also helps to dilate the ureter. Coming to the glandular structure of the prostate, the glands of the prostate, they are divided into three. Okay, one is the innermost, then intermediate, and then the outer one. The innermost glandular tissue where they are the simple tubular gland. The ducts of that open into the prostatic sinus above the colliculus. The intermediate glands are submucous in secretion and they have less follicles and the small ducts which open again into the prostatic sinus but at the level of the colliculus. Coming to the outermost main glands, the outer layer is the main gland of the prostate and they are numerous in number follicles and the long ducts of this gland, they again open into the prostatic sinus, but they open below the colliculus. The ducts which are present in the prostatic gland are about 12 to 20 in number. Coming to the slightly about, we'll touch for the histological aspect of it. So under the microscope, if we see, the follicles of the prostate, they are lined by the simple columnar epithelium. And these cells, they are under control of the hormone that is the androgens, which will stimulate this glandular tissue of the prostate. And at the old age, what we can see in the diagram, the red acidophilic large masses, which we call as a corpora amylosa, which are seen at the old age in the follicles. Okay, the internal capsule, which will lie between the main gland and the submucous gland, they divide the prostate into outer zone and the inner zones. The zones which are there in the prostate surgically for the clinical purpose, the zones are important. The internal capsule acts as a surgical capsule, which is helping also for the enucleation of the prostate while doing the surgery. In this diagram, we can see some zones which are for the surgical and diagnostic purpose. It is very important, and also the progress in the case of the carcinoma of the prostate. These zones are important. That is, one is peripheral zone, central zone, also the transition zone, and anteriorly what you can see green color, that is the anterior zone, which is fibromuscular vein. Now coming to the blood supply of the prostate gland, the blood supply which is there mainly the arteries which supply the prostate is, one is the inferior vesicle, which we have seen in case of the bladder. Also the middle rectal artery and internal pudendal artery supply the prostate. Okay, coming to the venous drainage, which is very important for us clinically, the prostatic venous plexus, which is present between the true and false capsule, is important while doing the surgery, and the blood which is received from the in the veins of this plexus, that is, one is from the deep dorsal vein of the penis. Also, the vein that drains into the vesicle and then into the internal iliac veins. Also, important point for the venous drainage is that is the venous drainage from the prostate. Also, they communicate with the vertebral veins of the Parsons. So these are the veins which are present which drain into the internal vertebral venous plexus. The importance of this in CA prostate, the metastases occur in the vertebra because of this communication between the prostatic veins and the paravertebral veins of the Parsons. And in that case, it happens, then the prognosis is bad. Coming to the lymphatic drainage, the lymph which is drained into the group of lymph nodes, that is the internal ilia, external iliac, and the sacral group of lymph nodes. Coming to the nerve supply, there is this parasympathetic and sympathetic. The sympathetic fibers are L1, L2, which are passing through this hypogastric plexus, coming that is preganglionic fibers, and then supply the prostate, as well as the parasympathetic are the pelvic splanchnic nerves, the fibers coming from S2, S3, S4. Parasympathetic are secretomotor to the gland. So the secretion increase when stimulated. Developmentally, we'll see in detail during the embryology, but just remember the glandular part will develop in the third fetal month and fibromuscular in fourth fetal month from the splanchnic mesoderm, which surrounds the urogenital sinus as seen in the figure. Now, we'll see the changes in the prostate gland according to the age. Okay. For the size, if you consider from age 20 to at the old age, 20 to 25, the gland is about walnut size. 35 to 40, it is of the golf ball. Still increases at the age of 50 to 60, which is lemon size. And 70 to 80, it is cricket ball size. So this is the size, how it varies according to the age. Also structurally, if we see in newborn, if we see, mainly there is a duct system and fibromuscular stoma, no much glandular structure. But before puberty, it start growing slowly and the rudimentary follicles start appearing. At the time of puberty, because of the androgens which are secreted more, there will be sudden and exuberant growth of that because of that the size of the gland becomes double than that of the neonatal cells. Above the age of 45, the mucus folds disappear and the follicles contain corpora amylacea. And actually the corpora amylacea increase as the age advances, moving old age, and progressively the gland may increase or may undergo the atrophy. Coming to the applied aspect, as in whole my lecture already I have told you about the applied aspect, but to specify the size of the prostate gland increases. The increase of the size may be one condition you should know, that is the BPH, means benign prostatic hypertrophy. The BPH means benign prostatic hypertrophy, means the size of the gland increases, but the increased size is benign. The cellular tissues are benign. So this is seen as age advances, and this benign prostatic hypertrophy is going to cause the obstruction to the urinary flow, and in that case the approach will be medical approaches. We give the drugs to reduce the size. If not, or if it is large, then you have to undergo surgery, where the surgical enucleation of the prostatic gland is done. The two surgeries, one that is the open surgery, where there is a suprapubic root is approached and then remove the womb, which is nowadays not much done. What they do is a transurethral resection, because open surgery, there is a lot of bleeding, and as we saw, there is a venous plexus rich blood supply. So the blood requirement also increases in this person. When we want to operate the blood bottles, you have to arrange a lot. Instead of that, now in advanced, what we do is the transurethral resection, where the bleeding is also the patient becomes more mobile fast. Second condition, that is the carcinoma of a prostate. The carcinoma of prostate, again, malignancy, where there is a tumor, as you are seeing in the picture, and the tumor will again have obstruction if it is immediately surrounding the urethra. Second thing is, as I told you, from the prostate, CA prostate, the venous drainage, because of this, the blood can veins, they communicate with the paravertebral venous plexus, and in metastasis can occur into the vertebral column, and the prognosis here is bad. So the carcinoma of the prostate, that depends the what is the gradation and the site of the carcinoma, depending upon that the approach or the treatment given to the prostatic cancer. So this is about my topic today. In short, I have declared, read about it further. Okay. So thank you.